So before into the actual content here, I should kind of expectations. When I say vascular pathology of the brain, what I'm really going to be focusing on are secondary kind of muscular issues that cause bleeding into the brain itself. This isn't going to be so much focused on ischemic stroke, certainly not going to be focused on traumatic causes of hemorrhage. So this is going to be kind of the more secondary things that you would be looking for in the setting of bleeding in the brain, particularly when there is an unknown etiology. This is trying to set expectations as to what you expect to see.
We'll start with a case here. This is a 40-year-old female who has hypertension at her baseline. This is a series of images taken from a non-contrast CT of the head. And you can see here on the right side in the basal ganglia, there's some high-density material, which is acute blood product, as well as regional edema here, as well as effacement of the sulci. You can see the kind of spaces between those on the left side. This is just a very classical picture for hypertensive hemorrhage we see frequently. So primary intracerebral hemorrhage, which is the overwhelming majority of bleeding into the brain in the stroke category, represents the minority of stroke. It's only about 10 to 15%. Obviously, hypertension is the underlying etiology, particularly in a long-standing setting of hypertension, so often just, transient episodes. Damage that it, rises from it comes first and foremost from the bleed itself into the brain, and then obviously the secondary mass effect and edema that happens. After this initial hemorrhage, you also get a chemotoxicity and glutamate toxicity from the cellular breakdown, which causes further injury. Are good predictors for outcome for patients. Typically, their initial Glasgow Coma Scale, the presence or absence of IVH or intraventricular hemorrhage, where this bleed is located, often obviously in the brainstem, things are more problematic. Older patients, they tend to not do as well, and then anything with a volume less than 30 tends to do better, but then greater than 30 tends to not do as well. So management of hypertensive bleeding, obviously medical management is still the standard of care, but there are, growing practices that are looking at surgical interventions for intracerebral hemorrhage. These are just some pictures from Greenfield's neuropathology demonstrating higher thickening of these small perforating arterioles that go into the brain substance that are typified within the basal ganglia. These are the deposition of these fibrinoid materials within the vessels themselves, which weakens them, or long-standing hypertensive periods. And then here's just an example of a hemorrhagic stroke into the basal ganglia, and obviously extending all the way up into the cortex. So one of the things that's near and dear to my heart, and I'm sure we will tell you, is I work very closely with angiography equipment, and that new angiography equipment has the ability to do CAT scans as well as just actually do catheter angiograms. And so this is a cool group with us in Germany who has looked at the use of technology to actually look at hemorrhage. And the top row here, you can see this is a conventional set of CT images showing bleeds within the gyrus rectus here on the right, subarachnoid bleeding into the lateral cistern and the Indian cistern, and then here an interparenchymal hemorrhage in the posterior part of the frontal lobe, again here in the basal ganglia. And these are the corresponding images taken from what we call a flat panel CT detector, angio-based CT. They're not as good. You can see they're very effective, at least in identifying these large hemorrhagic types. These are more images demonstrating similar types of bleeding. Again, the conventional images on the top and the flat panel images on the bottom. You can see that there is some degradation of these images as you get lower down into the skull base, and that's just partially related to the beam hardening artifact that we often see even with conventional CT. In terms of management, there's now interest. This is a group that we work with in SHAPE. This is another Siemens cooperative. This is the use of these types of technologies to actually use them to guide access. So you can see here's targeting of a bleed within the basal ganglia. Drilled a burr hole here in the frontal calvarium. What they're doing now is using X-ray angiography. You can see here this nice gentleman's hand, and they're putting a small catheter directly into this targeted bleed site. And then what they do is they place a catheter into the clot, and then over a period of days, the clot drains out. There's actually a big phase 3 randomized trial going on in the United States called the MISTY trial, which is looking at the effectiveness of this type of therapy. Change into what we call secondary types of intracerebral hemorrhage or hemorrhagic stroke. It's a 45-year-old male who had acute neck pain followed by collapse. What you see here is a series of CAT scan images. This is a non-contrast head CT showing high-density material down near the foramen magnum around the medulla. This is corresponding CT angiogram showing abnormal enlargement of the intradural segment of the left vertebral artery. This is in a coronal projection. You can see there's a small bleb here. Here's the coronary right vertebral artery. And this is what it looks like in sagittal profile. A still image from our angiogram that we saw, and what you can see here is this kind of, form dilation of the intradural vertebral artery. Here's the posterior inferior cerebellar artery. Here's the anterior inferior cerebellar artery. And this is the same picture taken from a 3D rotational angiogram. And here is the post-coiling projection. So there are coils deposited within that ruptured segment of vessel, or this is what we would consider a dissecting aneurysm. Interestingly enough, if you're into kind of rare types of disorders, this gentleman, when you looked at his other vessels, these are his internal mammillary arteries. Aneurysms were rising up of both of those. And then looked at his viscera, you can see there's a series of tiny little nodular aneurysms coming off of the vessels of his kidneys. The gentleman actually suffered from a systemic disorder called segmental arterial medialysis, and that's certainly nothing you want to commit to memory. So to say that disorder characterized by aneurysms out the kind of mid-sized vessels, and most of its morbidity is related to bleeding within the brain, as you saw in this particular case. The case, a 72-year-old female, a little more conventional case for an aneurysm, who presents with a cranial nerve 6 deficit. Here you can see a coronal T2-weighted MR showing this large aneurysm here of the cavernous segment of the ICA. This is it in sagittal projection on a digital subtraction angiogram or catheter angiogram, showing the internal carotid artery as it comes up and plugs into the base of the skull. And then there's this very large aneurysm here. And then here it is in 3D rotational projection, just showing its very large nature. This is a 23-year-old who's found down. Again, here's a non-contrast head CT. See here there's subarachnoid bleeding, again here close to the foramen magnum. Here's that corresponding image on a T2-weighted MR, but you can see here there's an interesting structure here centrally or at least posteriorly within the medulla. This is the angiogram that corresponds to this. So this is a frontal projection, this is a lateral projection, and what you've seen here is this is the right vertebral artery, and what you're seeing is this abnormally enlarged vessel here, and this is an aneurysm, but instead of it being kind of just a conventional aneurysm, as I've been showing you, this is actually related to a hemangioblastoma, was a particular type of posterior fossa tumor, which often is very vascular and it can cause aneurysms. So it's come in many different shapes and sizes. In the U.S., it's a pretty significant cause of bleeding within the brain. About 30,000 subarachnoid hemorrhages are related to aneurysms every year. And the prevalence varies depending on which population you're in. It's higher in Japanese and Finnish populations. In the U.S., it ranges somewhere between 3%. It manifests more often in patients in their 50s and 60s of life, and it's much more common in women than men. In terms of history of bleeding itself, there are many different retrospective studies that have looked at the growth and then the bleeding rate of aneurysms, and this is a few of the factors that we associate with aneurysmal bleeding: age, increasing age, hypertension, smoking, family history, previous subarachnoid bleeding, and collagen vascular disorders such as Marfan's disease, Danlos, polycystic kidney disease, etc. Aneurysms are obviously lumped into kind of one big group, but more logically they can be very dissimilar. You already saw a few examples. You saw a saccular aneurysm, which was a cavernous type. You saw a fusiform aneurysm within that vertebral, and then obviously dissecting aneurysms, which can look very similar to fusiform aneurysms, but ultimately they're all very different animals, and they all have different types of natural histories, but we kind of lump them in together, in part because of the scarcity of these latter two types. Majority of aneurysms are small, which makes sense, because they have to start small, and that's where you detect most of them. Some percentage of them are larger. Most of them are located in the intracirculation, but again, that goes along with the physiology within the brain itself. So this is a very quick slide looking at some of the pathophysiology related to aneurysm rupture. We have the endothelial cell line as the mechanoreceptor of the blood flow within your body. And for whatever reason, in certain locations and in certain types of people and in certain types of settings throughout their life, there can be disorganization or abnormal interaction between those mechanical forces, the flow and the pressure. That causes disorganization, which allows that cell wall to break down somewhat, and that changes its contour, which also leads to further aberrant flow conditions. And so this endothelial dysfunction allows for infiltration of different types of sites, macrophages, and other types of elements of the immune system itself. This leads to oxidative stress and other types of cell death eventually, and this in turn leads to further blowing out of that vessel and eventually to rupture. Note on this slide, we have no idea exactly where an aneurysm will form. We have certain hot spots within the brain, but if anybody would tell you that this patient will form an aneurysm at this location at this time, they're probably read enough of the literature on it to know that we don't know that yet. Here's an example of a case that we coiled, in the not so distant past. This is a frontal or AP projection, anterior posterior projection of a catheter angiogram. This is that same projection in the lateral orientation, the right internal carotid artery injection. So here's the peak segment of the internal artery. So that's this portion here, and then it rises up into the cavernous segment here. And then you can see this is the posterior communicating artery. We're turning into the posterior cerebral artery. You see here there's a pretty large aneurysm coming off of this. And this is the 3D rotational rendering of that same image. Place coils, which are these fine filaments of platinum metal, which go into the sac of an aneurysm and include flow. So I'm not going to go into the weeds in terms of how aneurysms are treated worldwide. Suffice to say that the majority are now treated through the blood vessels. Both clipping and endovascular treatment of aneurysms well established, and there's good literature to support both types. We do both types here at UCSF. I don't know if you guys have aneurysm treatment capabilities. If you do, I'm wondering if you guys also have catheter angiogram quality, possibilities. We can talk about that later. But this is how we do a lot of these things here, at least in San Francisco. A quick reminder, when we talk about the treatment of aneurysms, we consider this one completely treated, meaning there's no filling of an aneurysm. Residual neck or a little bit here at the base of an aneurysm, we consider that sufficiently treated. The natural history of these residual necks is benign. It's residual aneurysms where you actually start getting filling up into the fundus of the aneurysm that we consider untreated. So the National Subarachnoid Aneurysm Trial, this is the lone randomized controlled trial within space. This was a randomization of coiling to clipping of ruptured aneurysms of about 2,000 patients. Were randomized in a 1-to-1 manner, and follow-up patients were much less likely to be dead or dependent in terms of their outcome. I actually stopped the trial early in terms of the disability-free survival at 1 year, and that goes without saying. Obviously, most patients recover better from endovascular treatment than an open craniotomy, but there were some criticisms. Of course, there's no long-term follow-up. You have to start somewhere. And there are certainly aneurysms that were excluded because it wasn't that all aneurysms were incorporated. Some aneurysms were thought better for clipping or better for coiling with need for randomization. Importantly, the rebleed rate was slightly higher in the coiling group than the clipping group. We'll get to that in 1 second. ISAT is now at least 10 years old. They have enough data to make informed statements on patients with 10 years of follow-up. This was a paper published 18 years after its conception in the Lancet just last year. You can see here the data on the number of patients that they looked at. And what you're seeing here is a busy slide, but what you're seeing is this is the time from subarachnoid hemorrhage to rebleeding, and what you can see, this is the endovascular arm in blue, and this is the clipping arm in red. And what they found was that rebleeding does in fact occur with a high statistical significance in the endovascular treated arm than the neurosurgical or the open surgical arm. At survival time or death or dependence at 10 years, patients were again more likely to not be dead or dependent within the endovascular treated arm than the open craniotomy in the arm. And note that the number of patients who are having these is very small. So you can see here it's only 13 patients relative to 4. So these numbers are, again, scant. So you have to put all that in perspective. This is a study published by Claiborne Johnston. This is the CARET study, and this is really what drives a lot of the innovation in our field. This is the re-rupture rate of aneurysms, and this was a compilation of not only the ISAT data, but some other smaller studies. They found is that, not surprisingly, the more complete an aneurysm is occluded, the less likely you're going to have a re-rupture, and that's kind of what I was just talking about with that cartoon just a second ago. Imaging of aneurysmal bleeding, obviously we've already seen some, CT is the real workhorse here. It's the first study that we use. Subarachnoid bleeding is graded by the Fish scale, which talks about the volume or the relative distribution of subarachnoid bleeding. That's helpful in terms of understanding vasospasm risk, which we'll talk about in just a second. MR can be very helpful. I should also mention, obviously, CT. Radiography is the real kind of secondary. If you ever have bleeding into the brain of an unknown type, that's usually the first line test that we do for any type of workup. And what can be helpful, you could have seen on some of those images earlier that you can get increased T1 signal, and that oftentimes is related to thrombus within an aneurysm, which is not uncommon, particularly large ones. Ultimately, the gold standard remains digital subtraction angiography, DSA. This is catheter angiography. This gives us the most sensitive information, not only in terms of spatial resolution, but also temporal resolution, because it's very important to know how blood moves through a vessel as much as how the vessel looks itself. And of course, the DSA is that it looks at tubes as opposed to the surrounding structures, but that's why you have CT and MR to interpret that information. Last but not least, obviously, DSA also gives us the ability to treat things. It serves as both a diagnostic but also a therapeutic means for a lot of these patients. Vasospasm just a second ago. This is a patient who has a relatively high-grade subarachnoid bleeding, so you can see here the amount intravascular cistern, ambient cisterns, the interhemispheric space, and then the lateral cisterns on the Sylvian fissures, subarachnoid hemorrhage on the stark contrast type CT. Here's a laterally oriented posterior communicating artery aneurysm. And for clipping, you can see here these are the surgical clips, these metallic things. But what you're seeing here, this is a wire going up through the carotid siphon and into the first portion and the second portions of the middle cerebral artery. And what we're here, this is angioplasty. So vasospasm is a phenomenon that happens typically 4 to 10 days after a subarachnoid hemorrhage. Just as if you have a bruise or any type of blood product in your body, it has to be broken down and then reabsorbed. And for whatever reason, as the process occurs in the subarachnoid space, it irritates the vessels that run through it, both on the microvascular level, but also on the large vessel level, as you can see here. And so we typically will bring patients down during that interval and do an angiogram to assess for any evidence of vasospasm. We treat patients in one of 2 ways through the blood vessels. One you've seen here, which is angioplasty, where that means we take a very delicate balloon and we inflate that balloon in the vessel, pushing it open. This is akin to we see what happens patients in coronary disorders. But we also give medications. We typically give a calcium channel blocker such as verapamil, which helps transiently relax the vessels. And though the effect is only about 24 to 72 hours, oftentimes that's enough to get patients through the interval and to reduce their secondary stroke risk. Kind of in a more shot from a further distance or lower magnification. So these are before intervention, and you can see here this is the AP projection. Here's that middle cerebral segment. Here's the lateral projection. And here's afterward. And you can see how much more the MCA fill out better here than it was beforehand. If you can see this here, you can see this here. That allows the pressure head to affect those tissues better. I'm going to swim because I think those SMA clips aren't going to work really well. Just a nice picture showing what we call a serpentine aneurysm. And what you're seeing here is this entire here on this T2, actually the T1 weighted image. But what you're seeing here, this is a fused image between a catheter angiogram and an MR. This is something I did not too long ago. This entire structure is the aneurysm. What the blood is doing essentially is it's found a channel through the aneurysm to allow flow back to the distal portions of the parietal lobe. So though this looks like a vessel, this is actually just a channel through a lot of clot. So I mentioned that high T1 signal. This is all high T1 signal in a partially thrombosed aneurysm. That same image just fused. This would rotate, but I don't have the images ready to go, I guess. Not all subarachnoid bleeding, obviously, is related to aneurysms. I should mention, of course, that the most common cause of subarachnoid bleeding, which you guys probably know, is trauma. That kind of goes without saying, but nonetheless, I'll repeat it. But there's also non-traumatic subarachnoid bleeding, which is not related to aneurysms. And so we consider this as the classical perimesencephalic catheter, which is in the posterior fossa right around the midbrain. The thought is, at least, that this is related to rather small veins, but nonetheless, there is a lot of rad path correlation here because a lot of these patients end up just being discharged from the hospital and not having any sort of surgical intervention. The big number is that the rebleeding rate from what we consider perimesencephalic bleeding is extremely low, such that if you have a good CTA and you have a good, attribution for subarachnoid bleeding, the utility of doing delayed follow-ups is really not that helpful. If you have non-perimesencephalic bleeding, that's different. About up to a third of cases will have a secondary cause, i.e. an aneurysm or something else that we'll maybe talk about in just a second. It's very important to identify because it is secondary causes that have a surgical option. We have to help locate and then treat. 16-year-old with an acute headache. Here is a non-contrast head CT showing some bleeding within the deep portions of the left cerebellar hemisphere. This is the corresponding gadolinium-enhanced unrated MR, and you can see here there's some growth here or some blood clot within that cerebellum, which corresponds to this high-density material. But you can also see there's way too many vessels here in and around that blood clot. This is for an arteriovenous malformation. So this is a catheter angiogram. This is a right vertebral injection, your lateral and AP projections, and what you see here is enlarged branches of the superior cerebellar artery. A good tip-off of this is pathological, as this is the contralateral SCA, and look how small, this is what it should look like, and look how big this one is. That means it's going on with this large AVM here. This is the left vertebral artery here, and you can see here's the posterior inferior cerebellar artery, and it's all a series of lace-like vessels that come up and are also a part of that AVM. This is the frontal projection. Surgical case, and so this is after the fact, and the important thing to note was this patient is only 16 years old. 5-year follow-up, we did another angiogram, and lo and behold, there's recurrence of the AVM. And this is a practice that we've had for a long time. There's lots of literature to support this. The patients who are less than 18, certainly less than 10, and particularly in the setting of a rupture, it's very important to do a follow-up angiogram in a delay fashion. Typically, we do like 5 years because we do see a higher rate. We're comfortable that when we take it out, who has recurrent nosebleed. This is a gadolinium-enhanced MR. What you can see here are some tiny little lace-like vessels here, the portions of the temple lobe. And this is another selective cut from that same image up higher here. This is kind of the superior frontal gyrus on the left side. You can get a kind of smudge of vessels there. And this is the corresponding images from the angiogram. You see these smudgy little washy type things located here, and that was what corresponded there. And then if you look closely, there are these same little smudgy little things going on here in that temporal region. And then this is the external carotid artery. You can see that there's that same little washy things within the nasal mucosa that I work for. This is the palate here. This is down here's the palate. But you can see that same blushy thing. This is probably what's causing this. This patient has a certain type of shortness. So what we're seeing now is arteriovenous malformations. Aneurysms are common. AVMs are rare. They occur, on less than 20 out of every 100,000 patients. 100,000 people in the population. The male-female sex distribution is the same, and they present really kind of right in the middle of life. So it's kind of a pretty even distribution, which peaks around the 5th decade. In terms of the natural history, people frequently quote the 2 to 4%. That's based off of a lot of reference data. And that data is held up on a lot of other records. But we only have one randomized trial looking at natural history of AVMs. That's the Ruber trial. That was a evaluation of patients from up to observation versus surgical management of any type. I will go again into the details there. That rates of hemorrhage held.